Great. Thank you so much, Dr. Wayne. That was an excellent review, and thanks for finishing on time. I have just two cases, and I'm going to use a lot of the information that Dr. Wayne presented from City of Hope to kind of get an idea of how these trials have actually changed the way we manage in the upfront setting, in the maintenance, and also in the recurrent setting for my cancers. And it's all based on overall survival. So we're really excited that we can share that with you. I'm a GYN oncologist based in San Francisco, and I'm not smart like the med-oncs. I only take care of 3 cancers, and that's right there: ovarian cancer, endometrial cancer, and cervical cancer. I'm hesitating because even though I only take care of these 3 cancers, gosh, my son was interested in choosing a specialty. He asked me, he goes, "Hey, Dad, how long did it take you before you got your first job?" So I didn't get my first job at Stanford until I was 33 years old. So I studied, 4 years college, 4 years med school, and then we had to do OB-GYN, right? So I had to deliver babies for 4 years. And then GYN onc was another 4 years. So I was 16 years of studying women. And I have 2 teenage daughters, and I still don't understand women. They're very complex, intelligent human beings that I gotta get a PhD in, okay? Anyways. All right, so let's talk about advanced stage ovarian cancer. So I'm gonna show you just 2 cases, okay? And we can talk more because we have a lot of time. So my first case is a patient who's 47, enlarged pelvic masses, not really symptomatic, and she was found to have a pelvic mass on exam, and we ordered an ultrasound and a CT scan and the abdomen and pelvis. And I put asymptomatic there because of 2 or 3 reasons. One is most of the time, women, probably 30%, won't have symptoms, but 70% of the time, women do have symptoms. And what are these symptoms? When they present to see us, right, because usually I'm the front line in terms of assessing whether it's biopsy or take them back to surgery for debulking, they'll have symptoms. And what are these symptoms? Bloating, pelvic pain, early satiety, so they eat something and they get full early, right? What's wrong with those symptoms? Yeah, they're really non-specific, So I was preparing for my talk this morning. I was a little nervous, and I felt a lot of those symptoms myself, you know what I mean? And I don't even have ovaries. So definitely, it's really hard to figure out. There's no real symptoms that are associated with ovarian cancer that we could tease out that is due to pelvic mass. And so she had a CT scan, and look at that CA-125. It's up in the 3,000s, and her CAA is normal. So you can kind of point towards that this is possibly a ovarian cancer. She ended up getting a CT-guided biopsy. Pathology showed serous cancer, likely from the ovary, and she underwent neoadjuvant chemotherapy, Taxol, carbo, and then she had interval cytoreductive surgery. And even after 3 cycles of chemotherapy with response, right, 3 cycles later, we still saw cancer. So we staged as stage 3B, ovarian cancer. BRCA was wild type, right, which is pretty common, right? Because most of the time, how many percent of the ovarian cancers are actually BRCA? What do you guys think? Who made BRCA famous? She was married to Brad Pitt. Yeah, she was on the front cover of Time magazine for having all this risk reduction surgeries because she was found to have BRCA from her mom. They made it seem like she cloned the gene, but Angelina Jolie did not clone the gene. Mary Claire King, she cloned the gene. They think she may be the next woman to win the Nobel Prize because it really changed management. However, that's only 10-20% of ovarian cancer patients. How did the other 80% get ovarian cancer? What risk factors do you have for ovarian cancer? It's not a virus, right? It's not a virus, right? Not really obesity, right? Those are the other two cancers, right? It's hard to get ovarian cancer. We think it's the incessant ovulation theory. What that means is that, hey, every month, all you young ones out there that are still ovulating, you're hurting your ovaries every month. Every 30 days, you're rupturing that surface of the ovary. That damage, repair every 30 days is what causes the increased risk in ovarian cancer. How do you stop that damage? Other than doing surgery, removing it when you're 15, right? You can't do that, right? Right. Or do it naturally. Just have 15, 18 babies, right? And then breastfeed them for 2 or 3 years after every baby. But that'd be really expensive. I'm paying for 3 kids' private tuitions right now. That's not sustainable. So the cheapest way, right, to do it is basically birth control pills. We've even taken patients who have BRCA, they're sisters, they're twin sisters. And if one of them took more birth control pills, more years of birth control pill, you can even use environment or use drugs, right, to risk reduce their chance of getting ovarian cancer. So the twin actually took more OCPs. Even if they're both BRCA1 positive, there's significant decreased risk. All right, so that's 90%, right? Or 80, 90% are BRCA wild type. Her HRD status was positive. Homologous recombination deficiency, test that tumor, and half the patients with ovarian cancer will be HRD positive. What do we do? So I'm gonna just go around the room, right? Let's figure this out. So you guys gotta participate, okay? So don't be a fun sponge. Have you heard of that? That's what my daughter taught me when she was in high school. It's like, you're not fun, you know, you just soak up you're a sponge that soaks up all the fun. All right, stage 3B, ovarian cancer, HRD positive, BRCA wild type. She responded to the neoadjuvant, so let's review this. She didn't get Bev up front. She just got chemo, 3 cycles, and then she ended up with interval surgery with us. What do? Choice A, keep going on Taxol carbo for 3 more cycles, and that's it. Follow surveillance. Choice B, Taxol carbo for 3 more cycles and do niraparib for maintenance. Choice C, add Bev on your 4th cycle after surgery, and then just do Bev maintenance. Choice D, do all that, but then add olaparib in the end. All right, how many in the room would just do A? Okay, I like it. So you guys believe in that maintenance thing for our ovarian cancer. How many would do B, niraparib? Just do a PARP. No Bev, just do a PARP. Okay, no takers. How many would do C, do Taxol carbo Bev and just do maintenance Bev? Based on what we reviewed at GOG 218, ICON 7, all of them said. How many would do D, add PARP and Bev? Nice. I like it. Based on what? Well, Dr. Wayne went through with us the Paula study, right? These are the patients who I got randomized to either Bev alone, right, after your chemotherapy. So they got, a year and a half worth of Bev. That's the red box there. And the other half got, or 2-to-1 randomization, got the PARP added to the Bev. So basically I got a PARP inhibitor and a antivascular drug, right? This is a 5-year progression-free survival. I don't think we've ever seen this in our cancer space, right? In particular, ovarian cancer, where 70-80% of the time they're found with advanced stage disease, and their outcomes is 30-40%, right? So to show that huge benefit from 19-20% to 46%, that was a huge breakthrough for us for PARP inhibitors. And more importantly, over the last few years, they're able to show overall survival. And we haven't been able to demonstrate, not just progression-free, we haven't been able to demonstrate overall survival since probably the days of intraperitoneal chemotherapy, right? The days of taxane. We brought taxanes into the world, right, with Dr. Bill McGuire. And so to have an oral drug bring overall survival despite crossover, right? Despite long follow-up, 7-8 years, you're still able to show that something that you did in the upfront setting impacted overall survival, right? So these are the paradigm shifts. So first-line management of ovarian cancer with overall survival benefit. So not only do we show it on the right side here with the Apollo 1 study where you combine PARP inhibitor with a antivascular drug, Avastin. On the left, you don't even have to give Bev. If you're BRCA positive, we have that Solo 1 trial that says that just take PARP for 2 years and you can impact overall survival, right? So this is the first time that a maintenance drug, right, and also an oral drug, we're able to show that there's overall survival benefits. So this is a paper we wrote about 3 or 4 years ago. We kind of modified it a little bit as things have changed. Like how do we select for new upfront treatment regimens for advanced stage ovarian cancer? So on the left, so you get an ovarian cancer, let's review here. You got 3 decisions you got to make. First, do I take him to surgery? Or do I give him chemo first? On the left, that's the first decision, right? And more data in ASCO is coming out showing that the upfront surgery probably is showing comparable results to interval surgery. But upfront surgery is much more morbid, right? The more I have to do, the more risk for the patients and the more complications, the more risk of needing an ostomy and all that stuff. So if you can get that tumor significantly decreased down with some chemotherapy, neoadjuvant, and interval cytoreductive surgery is a good idea. Decision number 2, do I add Bev, right? Do I add Avastin to that drug? Sue Hellman was our chancellor for a while from Genentech, and she described Bev like really cool. She says, basically, when you have a tumor that grows to beyond the size of a BB gun BB, it needs blood to eat. So block it. Judah Folkman was actually a pediatric surgeon at Harvard. He was the one who said, man, forget messing with the genes. We're all trying to do gene therapy in the 70s and 80s. He goes, man, forget the genes. Just mess with the tumor microenvironment. Starve the cancer with these monoclonal antibodies, and that became the bevacizumab. So we definitely show bevacizumab improved the progression-free survival, not OS, just PFS in all of our trials by 6 months. So it helped, but it didn't change OS. And it wasn't until this decision 3 when we added the PARP inhibitor, oral PARP, for the BRCA patients. You see that? If you don't give Bev and you check them, they're on top right there. See that? BRCA mutated, then you could just do olaparib. If you took Bev because they had ascites, stage 4 disease, whatever reason why, whether they're low risk or high risk, we found that they also benefit from PARP in both ways. And you added the PARP olaparib with Bev, then you see the OS difference. And that's why I boxed up those 2 red boxes for you, because these are the 2 trials and those combinations that showed OS benefit. All right, so this lady ended up getting the maintenance PARP. Unfortunately, she didn't do so well. Within 6 months from her last cycle of chemotherapy, her C125 started rising, and her CT scan shows some peritoneal nodularity. We took her back, right, because she's got 6 months only. Instead of doing a secondary cytoreductive surgery, we took her back and biopsied it and showed that it's HRD positive, right? Didn't change much from her before. FR alpha positive and HER2 3+. What do you do now? Yeah. So D, MERV, A, hey, she's platinum resistant, right? 6 months. Just give them weekly Taxol, right? The Aurelia study, right? Maybe just give them weekly Taxol with the Bev. Or wait, 6 months, she's kind of sensitive. Maybe we could do doublet again, do carbo again. And this time, change up the PARP. Maybe change from olaparib to niraparib. Does that work? I don't know. C, wait, she's HER2 positive, 3+. Man, you heard Dr. Hope Rugo talk a lot about, this Enhertu drug. So what do you guys do? How many would do C? How many would do D? How many do C? Okay, I got it. You got about 3 or 4, you guys, right? It is FDA approved. It is HER2 3+. You don't have to worry about eye toxicity, right? So you do MERV. But This is the MERV study, the Mirasol study that showed OS benefit, okay? I like the fact that all of you guys probably lean towards mirvetuximab because of the fact that this trial is the phase 3 randomized trial, not just like the Destiny trial of the Enhertu study, right? It only is a phase 2, only 40, 60 patients. This is hundreds of patients, 500 patients, and when they randomized them, they basically showed that mirvetuximab versus investigator's choice, which is either Taxol, Doxil, or Topotecan, significantly improved overall survival. This is in platinum-resistant disease. Man, these are the patients that don't do well. Whatever drug you throw at them, you'll probably have 10, maybe 15% response rate. And here, you're getting 3 times that. And not only did you improve response rate, improve progression-free survival, you actually led to OS improvement in the platinum-resistant space. That was huge for us. Got it? So good choice. All right. So this is current management. These are paradigm shifts. Shift 1, we added Bev in 2014, 10 years ago. 2017, we added all these PARP inhibitors for recurrent disease. And now we have this mirvetuximab study looking at an antibody-drug conjugate, right? All right, that's uterine cancer. That's ovarian cancer. Ready to do uterine cancer? All right. So uterine cancer is a problem. Why is this a problem? Take a look at this. The number of new cases in 1995, 30,000. Look at today, uterine cancer above that melanoma. It's 60,000. Man, I hesitate here is because I gave a recent lecture at University of Colorado, and this fellow introduced me. And he says, Dr. Chan trained in the late 1900s. Should have punched him. But I did, right? I graduated medical school in the late 1900s. I graduated medical school in 1995. That's when it was 30,000. Look at that today. Man, this is crazy. How did it go from 30,000 to 69,000 new cases of uterine? And what's another problem? Man, as of the last 10 years, right, it beat out ovarian cancer. Even our textbooks are outdated because they still say ovarian cancer is the most deadly GYN cancer. As of 2024 and 2025 data on the right side still shows this too, that uterine cancer is creating more or causing more deaths per year, right? But it's just because it's the sheer volume of cases. That's why. It's not necessarily, most of the time uterine cancer is still in the stage 1 disease, but there's just so much of this uterine cancer in the young and the African American women that we're seeing in that disparity that you heard on this morning on breast cancer. All right, so that's definitely a problem. We don't know how to hold that back. We don't know how to slow that down. We don't know what's causing this. This is all about obesity. Why is it happening more in African American women and the minority population? Oh, here's a case. Ready? This is our last case here. 71-year-old with postmenopausal bleeding. She had cramping for about 6 months, CT scan. She had bleeding, 71. She shouldn't be. They saw a uterine mass on ultrasound, and they also saw liver lesions. I did an endometrial biopsy. It showed an endometrioid uterine cancer, grade 3. And we think it's stage 4B because she has some upper abdominal disease with a mental disease. Molecular features, MMR proficient, HER2 negative, ER negative. What do you do? So let's review. 4B, uterine cancer, MMR proficient, HER2 negative. Just give Taxol carbo, add Bev. Right? There's a study by Carol Agajanian in 86P, right, GOG, that shows adding Bev may be beneficial. How about the dostarlimab? Dr. Wayne talked about the dostarlimab, right? Jemperli. And then Taxol. What about Pembro? Wait, can we just do a non-chemo combination? Pembro, Lenvima, and forget chemo? What do you think? C, D, or E? Yeah? How many would do C, the dostarlimab? How many would do D? Just do Pembro. Okay, I see some hands for Pembro. How many would just forget chemo, Taxol carbo? Just give them Pemlem. What do you think? No? No takers? All right. OS benefit, right? We're talking OS here, right? So the Ruby trial basically showed overall survival benefit in the advanced stage and recurrent endometrial cancer. On the left side here, you see the OS benefit. The data matured over GY018, which is the pembrolizumab study. So this is the first study that we showed in endometrial cancer that we can improve overall survival. Definitely showed a bigger benefit in the DMMR group, deficiency in mismatch repair, which is on the right upper corner there. But there's also some clinically meaningful benefit in overall survival in the MMMP group. This data was not big enough, so that bottom right is more of an exploratory analysis. But definitely, you see some separation in the curves over there. So these are our paradigm shifts. The Ruby trial in the upfront setting, at first it was for DMMR. In 2024, it opened up for all comers, whether you're DMMR or PMMR. You can get it. I circled that because that's the first trial that showed overall survival difference. But you can also use Pembro, it's FDA approved, and you can use durvalumab too. That's also approved for deficiency in mismatch repair. Anyways, so she ended up getting 12 months of maintenance dostarlimab and chemotherapy, and afterwards she had relapse in the lungs. What do you do now? Taxol carbo bev? Hey, she didn't see bev, right? She saw checkpoint inhibitor. What about Taxol doxil? Maybe we'll change up the chemo. Taxol carbo with Pembro? Change up the checkpoint. What do you think? Or would you do Penlem? Penlem? Yeah, agree. All right, this is the trial that showed OS benefit, right? So every choice I suggested, I got to show OS, right? And this is the Keynote 775 data that they randomized patients with advanced metastatic recurrent disease that must have had disease progression after chemotherapy, and they showed that Penlem is able to improve overall survival in the PMMR population. Yeah? So there's another OS benefit. So that changed management, right? Penlem for recurrent uterine cancer after they failed chemotherapy. So this is a paper we wrote again looking at how do you divide up. Just like we wrote that paper on dividing up ovarian cancer, we also help clinicians looking at biomarker guidance. So this is all DMMR group. Next slide I'm going to show you is the PMMR group, okay? So in the DMMR group, you can use dostarlimab, Pembro, or durvalumab, right? And some of these trials are different based on the cell types, whether it's endometrioid versus carcinosarcoma. So we kind of divided it up. You can download this reference and look. And in the PMMR group, it's a little bit more complex just because you could potentially have serous cancer, maybe due in HER2, right? And if you have P53 mutation, maybe you can add Avastin. There's some suggestion of that. But almost all the time, right, on the right side here, you see when you have PMMR population, the go-to combination is pembrolizumab, which is what you guys picked. Yeah? 3 more minutes? Do I have time? Okay, let's do it. So I don't have a case for cervical cancer because I thought I'd run out of time, but we have extra. Cervical cancer, I'm just going to show you some of the paradigm shifts, right? Bev improved survival, GOG 240. One of my colleagues, Krish Tiwari, showed that at Irvine. Adding Avastin improves overall survival in cervical cancer by about 3 or 4 months. The middle red there, you see, in 2023, man, that's in checkpoints came in to our world, right? It's really interesting. You know, checkpoint inhibitors just don't work well in ovarian cancer. We've had 8 trials in ovarian cancer that have failed. But man, it works well in uterine cancer. Almost every trial it showed benefit, and it also works really well in cervical cancer. Why? Well, you know, when we talk to medical students, when I'm at UCSF, you know, we say, oh, it's because ovarian cancer is a cold tumor versus a hot tumor. What does all that mean? You know, there's a very nice paper you guys should read. It's by Bert Vogelstein. He's from Johns Hopkins University. What he said is, when you have cancer that's damaged by the environment, that's induced by the environment, these checkpoints work. because these cells have a lot higher mutation burden. But when you got cancers that come from within, like ovarian cancer, right? There's no environment hit, like melanoma, checkpoints work. Lung cancer, smoking, checkpoints work. Cervical cancer, how do you get cervical cancer? Virus, man, checkpoints work. It's environment, right? Uterine cancer, maybe obesity, 60, 70%, they think it's attributed to obesity. These checkpoints work, right? And then, so when you use the checkpoint inhibitor on cervical cancer, it works in the localized setting, which is the Keynote A18 study. You see the middle bottom there. Also works in the metastatic recurrent advanced setting, which is the Keynote 826. And these are all pembrolizumab. And then the recurrent setting, you got the tisotumab, and that is the antibody drug conjugate against tissue factor. And that is the only phase 3 trial in recurrent cervical cancer that failed chemotherapy. Tiso beat out, or Tivdak beat out chemotherapy. So that is also our number one go-to drug. So and about a couple of months ago, we published this looking at cervical cancers, how do you translate the clinical trials data. So we broke up the disease in different stages. You see on the left side there, right? Stage 1 to 1B. You could do induction chemotherapy with interlace. The middle row there, this is the stage 3 to stage 4. This is when you do chemoradiation with immune checkpoint pembro. And then the metastatic recurrent, depending on if your CPS score greater 1 or less than 1. These are how we select treatment at our center. And this is just a couple months old from gynecologic. All right, how far are we from global eradication? Man, we got to get rid of this cancer. When this paper came out, or the vaccine first came out in 2006, man, I thought by the time I'm done with my career, right, which is 30 years later, I shouldn't be seeing cervical cancer in my office anymore, because you should be able to vaccinate this cancer away, right? How are we doing? Look at United States, the Americas. Man, you're up to 70, 80% vaccination, right? And the best countries are actually Australia and Sweden, those areas. And you can see this is a national reduction in cervical cancer. Look at where the areas where cervical cancer is significantly decreased. That solid light blue there, right? And then high-grade dysplasia also, warts, all due to the vaccination, right? And the vaccination can be given mostly at the age of 11, right? And this is a CDC guidelines, but it could be given as early as the age of 9. And now you can give it up to the age of 45, right? For the vaccine, the series of 3 vaccine. When the vaccine first came out in 2006, I still remember I was on junior faculty at Stanford. There's a local paper, San Francisco Chronicle, asked, hey, what do you think about this vaccine? I said, this vaccine should really eradicate cervical cancer from my practice. Within 20 minutes of that paper getting published, I got hate mail in my Stanford email. Why? From who? Yes, the conservative religious rights groups. They said, what are you doing to our young girls? Because in 2006, it wasn't approved for boys yet, right? It was only approved for girls in 2006. It wasn't until 2008 it became approved for both sexes and stuff like that, right? So when it got approved, I was going, man, we hope to eradicate this cancer away. And then they go, what are you doing to our, you're going to promote early promiscuity to our young girls, right? I kind of get it. I'm an Asian dad, Chinese dad, right? And to think that I got to vaccinate my daughter at 8.5, I'm thinking, man, I better vaccinate them. They're turning 9 next month because they're going to have sex when they're 10 years old. Oh, that hurts me as an Asian dad. You know what I mean? But fortunately, both my daughters, on Father's Day, they promised me that they're not going to have sex until I'm dead. So then... She goes, "Dude, you're going to die early. You better get somebody to taste your food at lunch." All right, I'm just joking. All right, so I'm done, okay? So this is what we reviewed. Advanced ovarian cancer, we talked about maintenance PARP, who and when. We talked about the novel drug, mirvetuximab, for antibody-drug conjugate that improved overall survival. Olaparib and Bev improved overall survival in ovarian cancer, HRD positive. If you are BRCA positive, you could just use olaparib alone. SOLO-1 improved overall survival. Endometrial cancer, clearly, dostarlimab and pembro improved overall survival. And then also immune checkpoint inhibitors work well. ADCs with Tivdak and tisotumab also improved overall survival. But more than anything else, we got to prevent this cancer. Thank you so much for having me.
So I have a question about testing for folate receptor alpha in recurrent ovarian. Do you do it on the primary debulk tumor, or do you rebiopsy the recurrent site to check for folate receptor alpha? In your platinum-resistant case, for example.
Yeah, that's a good one. Unlike most of my colleagues just do full, panel testing on the upfront setting. I'm still kind of old school because I still think upfront treatment probably takes care of 30-40% of our patients, So, so I test it when the cancer recurs. I only do upfront, I'll do BRCA testing, NCCN guidelines, right? ASCO guidelines. Every patient with fallopian tube, ovarian, and peritoneal cancer has got to get BRCA germline testing. And then I also do HRD testing, because HRD testing guides me whether or not I should use a PARP inhibitor or Avastin combination. And then when the cancer comes back, 30-40%, then I test them for folate receptor. And sometimes I may take them back for a biopsy, and if I have a piece of tumor, I'll test that recurrence first. You know what I mean?
Any other questions?
I have a comment. Dr. Lopez gave a talk on integrated medicine. I really loved that talk, but it just triggered my mind when I was talking about 30-40% survival. So when I was at Stanford, okay, these Chinese patients and Asian patients came up to me and they go, "You know what? What you tell us and what the naturalists and the herbalists tell us are very different. You need to set up a conference like this on a Saturday morning. And then I want to hear on this side the herbalist, and on this side I want to hear from you guys, the Western doctors." I'm like, "You want me to debate herbalist? Dude, I'm going to kill him." You know what I mean? So I show up with all my data and all my trials. What do they have? They got nothing, right? They don't have trials until, what you showed today probably, So then, after I present all my data and I had all my onc people come, herbalist comes over, right? And he goes, "Yeah, it's really interesting. Dr. Chan shows us all his data." He goes, "But have you noticed his survivals are 30%? That means 70% of his patients are dead." He goes, "Let me show you Mrs. Jones. Mrs. Jones went to UCSF, and they gave up on her. I gave her this herb, this herb, this herb. She is 18 years out from her cancer. Let me show you Mrs. Smith. Stanford gave up on him, and I gave him this herb. And I didn't know how to argue against that, but everybody started clapping, right? Their anecdotal experiences, man. He didn't show the patients that didn't. I didn't even know he treated a fungus ball or a cancer. I have no idea. There's no biopsy, right? But I couldn't say that. And then the worst part was, man, I was like, how could you do that, right? I can't teach evidence-based medicine to this cohort of people, right? So then I was leaving. And he goes, "You know what? Let me make one more comment." He goes, "There are white doctors that believe in what we do more than Dr. Chan. He's a Chinese kid that's trained in Western medicine, and he forgot his heritage." Terrible. Never do that conference again. That's what I learned. All right, any other questions?
Question there.
I just have a very quick question for you about your second case study that we looked at. So when she recurred and you used LEMPEM, it's kind of a data-free zone because that study, those patients had been IO, they had not seen it, they were IO naive. So are there studies that are upcoming? Are there real-world evidence studies that are going to see about IO after IO? So in that case, you changed from dostarlimab to LEMPEM, but is there evidence to suggest that's working?
Yeah, hey, good point. So what she's mentioning is you got this patient who actually went on immune checkpoint inhibitor in the upfront setting. When they recurred, you know, the NCCN guideline category 1 is to do Pembro again, Lenvima, right? It's an immune checkpoint again in Lenvima. Are there data that's coming out? Yes, but there are institutional studies, 2 of them. One, Peter Rose from Cleveland Clinic, he wrote a series of patients, man, no more than 12 patients though, okay? And these are the patients who actually had DMMR, they got Pembro, and when they recurred, they got Penlem. And they show continued response, 20, 30%. The other series came from a Japanese group, and that was in a poster at ASCO. So yes, there is gonna be more and more emerging data because most of us are putting these checkpoint inhibitors in our upfront advanced stage uterine cancers and stuff like that. So we had a poster up at ASCO basically showing 840 patients with recurrent advanced stage uterine cancer. Man, we were shocked. And the reason why we were shocked is because 70% of those patients, those cancers recur within 6 months. 70% recur within 6 months. In ovarian cancer, it's flipped, right? 70% will have a great response. They won't be resistant, right? Platinum resistant or treatment resistant. So our paper was basically, hey, does this treatment resistant occur in uterine cancer? And sure it does. And most of these patients, man, they don't do well. If you look at the RUBY trial, look at the GY018 trial, that median PFS was like about 7 months. So these patients with advanced and recurrent uterine cancer, man, that's why the number of patients who die every year is much higher.